Welcome back to the Sports Medicine Project, episode 109, where we are talking about the beautiful bony navicular stress fractures. But before we get into that, I must introduce, welcome, Season 2.
Season 2.
Kelly Kortic, co-host, physiotherapist, and PB marathon runner.
Oh, we haven't even told them about that because it's been so long.
Yeah.
I feel like I haven't been behind the mic in months. It has been months.
Yeah.
I feel fresh.
If you're a new listener or a previous listener, we had a probably 3-month hiatus because Kelly went overseas, then I went overseas, uni was really busy, work was really busy, and we always wanted to continue doing the podcast, but we wanted to come back, have it fully planned out, have a little bit more...
Add a bit more quality.
Yeah.
And structure.
It wasn't good quality. Yeah,
no,
a bit more
it was
structure.
a bit off the cuff previously, but we've been a bit more organised. We have been.
Yeah, it's been good. So it's going to be a similar format, which you would have heard if you haven't listened. Go back an episode, and it'll be an explanation of season 2. One of the things that we truly enjoy about listening to other people and talking amongst other people is the talking and the learning and the dialogue. So we're still going to have our interview style where we bring on an expert to talk about things related to sports medicine and musculoskeletal medicine, but we want to put a little bit more emphasis on this weekly recap because people were saying, well, you were saying that the listeners that you really enjoyed it, where we talk about what we went through in our clinical week, our clinical reasoning, but we want to bring the guest in to talk about their clinical week or something that they found in the research or something that was related to clinical life that they found, which is so cool. Like, you imagine our previous guests, someone like Ebony Rio, who's been on the podcast, I think episode 70-something. Imagine her talking about her management of an Achilles tendinopathy or her critiquing our management, which is awesome, and we're really open to learning, so I think that's going to be it.
And that was the reason that we actually started the podcast, is because we would come home from our day and we would just discuss complex cases. And we were like, we should bring this onto the podcast. So I think it's going to be, fun to talk about.
Yeah. We've got a couple of new episode types coming as well, where we're going to have people come on and discuss a particular pathology. I have 3 or 4 podiatrists discussing heel pain, someone talking about hamstring tendinopathy, 2 orthos talking about midfoot osteoarthritis. So it's going to be really fun and we're really excited. The other aspect is now it's on video. So this will go up on YouTube as it always has, but on Spotify, if you open your phone, you should see the video and the audio, and it will have the chapters because we're using a different tech, which is going to be really fun. So you'll be able to see us in real time learning. Hopefully you'll be able to see the epiphany when you tell me I'm wrong and go, oh, how did I not know that for 5 years?
Yeah, and the animations as well. People haven't been able to see how big your eyes get when you get really passionate about things. Although probably people can just feel it. They probably don't even need to see it.
One thing with that Insta360 camera, so if I'm filming something, it films you as well. And I was watching a couple of videos from the weekend where we're up presenting on the Gold Coast, and I turned it around and my eyes are so intense. I'm like, far out. I wonder if people just get a little bit freaked out. Like, is this guy all right? He's got something going on neurologically. Someone put a tuning fork out for a neurological exam. But yeah. Anyway, we're going to do our clinical recap for this week. So you want to go first, and previously we did Monday to Friday, but we're just going to focus on 2 weeks. The guest will bring in 2, just so we can keep it pretty concise within kind of 20 to 30 minutes. So I'll go first with my clinical recap.
Go for it.
Been away for 6 weeks, and it's more of a general principle, I guess, but when I'm seeing someone regularly, because the time is so small, I might see them a week or 2 weeks or 3 weeks for these typically persistent foot and ankle conditions. The needle moves pretty slowly in their function and their pain, but I had a bilateral insertional Achilles tendinopathy that I saw just before I went away, probably about 3 weeks before I left for 6 weeks. And typical, going into lots of compression, trained a lot, trained in the gym, and was doing a lot of fast rates of loading. We minimized that and took out all the compression and netball in the gym and walking, popped some heel lifts in, saw them 2 weeks later, about a 30% improvement in their pain, which is great. And I was concerned, like, now I'm going to start more of the loading, start to reintroduce some things, but I'm not going to be able to see you as regularly as I typically would. I'm just going to give you I'm going to have to give you a bit longer. So, hey, I'm going away. I'm going to see you in November, which was 7 weeks from that date. And I saw them, and they're about 90% better. we didn't do anything but a little bit of strengthening, just implemented some offloading, and there's obviously some natural history involved, but it just made me reflect on when I'm seeing someone so regularly, perhaps it doesn't need to be as regularly if they know what's going on and they understand. Because I understand there's a little bit of you motivating them a little bit more, showing them they're on the right track, but it was a long period of time and they just slowly gotten better.
Would you not have considered to book that patient in with someone else while you're away?
They were happy just to stay to see me.
Mm-hmm. They didn't want to see anyone else.
Yeah,
I understand that. It's hard, like when you've got long-term patients who have built a lot of trust and they just want to see you and don't want to bounce around to other people and have to kind of go through it all again. But I guess in that scenario, what was your advice to her? Like, that's great that that person got better. What would your advice be if they had a flare up? Did you just tell them to self-manage and regress it, or did you tell them to come in and see someone, or how? What if it wasn't as successful as it was?
Yeah, well, just typical. I mean, every tendon I see gets a pretty general principles of what a tendon's going to behave like. I fully expect it to flare up. It's going to take a long time. If it flares up for a couple of days, that's okay. Take it easy, let it recover, and get back on the horse and continue with what we would be doing. And I tell everybody that with most conditions, because it's pretty good advice, I think, because it's going to happen at some point. And then if it's persisting for longer, then there's the opportunity to come back in. But even in saying that, it's going to be the same advice of you probably just need to be more aggressive with what you're offloading. So if they really understand what's happening, they can manage it pretty well. But just made me think of natural history, and if we give people a little bit more time, there are these big changes. And when I'm seeing people in the shorter term, probably not getting as down if they're not progressing as quickly. And I tell people that if I'm only seeing you in 2 weeks, I'm not expecting you to come in and be 80% better. I'm expecting it to be probably a little bit better. You're feeling a little bit better. You can do a little bit more, and that's good progression, and it just takes a long while. But I just wonder if it could probably maybe be a little bit longer. Obviously, it's case specific, but as some of these persistent
I think it depends on when you decide to spread things out too. So I think for those kinds of conditions, you kind of need somewhat regular follow-ups initially to get them on board, make sure they understand, navigate what their threshold is, ensure that you have given them the appropriate amount of loading, not anything that's going to be significantly flaring them up, but not anything that's underloading as well. I think it takes more regular follow-ups to work all of that out at the start. But then, yeah, you're right. Maybe in a month or 2 months down the track, at that point, with those persistent conditions that we know take 12 months to turn around or start to improve or get back to sport or whatever it might be, then I think spreading it out. Although in saying that, an ACL reconstruction...
Different.
Yeah.
Different. I mean, if you see medical practitioners, we see some doctors and other health practitioners, and you just give them a little bit of advice. They already know most of it, and you just kind of consolidate it with them, because it's not going to change that much. I mean, if they have a flare-up, I'm just going to tell them to not do less of what they were already doing, or we need to go a little bit slower with the progression. And I feel as though if they already know that, they can self-manage pretty well, other than if it's really sore, take it easy, let it recover. If it's really, really sore, maybe come and see me. But otherwise, you're going to let it recover and then continue to progress. So, if a good example is Sever's condition that I see a lot. I only see them maybe 2-4 times max. Give them a lot of stuff to unload the heel. Tell them it's not dangerous to have a little bit of discomfort. Keep active as much as you can. But if it's really bad, unfortunately, you just have to do less. And otherwise, there's not much more I can do other than offloading it.
Do you kind of categorize people into copers or non-copers?
Yeah, I guess probably subconsciously. I know, and people will tell me that as well. Sometimes I'll say, I'm going to see you in this period, and people say, oh, what if I see you a little bit sooner? Or I'll give it up to them. Do you think that if we give it a couple of more weeks, are you comfortable with that, or would you potentially see me sooner? And that's rarer, but I think it has a place.
Yeah, that's definitely something that I will consider, is if I feel as though they're a coper or a non-coper. And yeah, you're right. I think they give you, either they tell you that themselves, or they definitely give you hints into if they are or not.
Yeah.
And that's probably one of the big things that dictate how frequently I might follow up with them.
Yeah, I feel if you can hear the keyboard typing, and if you watch Joe Rogan, we're trying to do a lot, but Jamie will look stuff on the computer, and then we're talking, and we'll go, and there's all these memes about it, go, Jamie, look that up. So I'm going to say to me, Blake, look that up, but obviously it's just me.
So you're going to talk in first person.
I'm going to break the fourth wall. But I remember seeing this this study that I just looked up here. Is one enough the effectiveness of a single session of physiotherapy?
Oh, wait. I didn't hear any of that.
What I looked up, and I've seen this previously in multiple studies, where they compare one session versus multiple sessions of physiotherapy and track them over time and see if the outcomes are better. Now, of course, the first thing you think of is it matters the person, it matters the context, it matters the condition. There's lots of things, but generally speaking, and it is funny to see these sessions. So the conclusion from this one, which is called is one enough the effectiveness of a single session of education and exercise compared to multiple sessions of physiotherapy. Adding a supervised multimodal physiotherapy session did not result in better clinical outcomes when compared to a single session. So what we're going to do on this podcast is we're going to drop the link in the show notes. I've just found the study and I've read the conclusion. That is not in any sense how we recommend to interpret research, but it is interesting and we are going to drop it in there. So if you, as the listener, want to find out more, just click the link below and it'll open it up.
I have also read quite a lot of studies recently even, well, recently as in before I went away, that suggested the opposite of that.
Do you know it was in a specific condition? Because this one's shoulder and back pain.
I would guess it would be some sort of chronic thing that you tend to see a lot of people for. I reckon I could.
Blake, look that up. Do you remember what it was called?
Blake, look that up. I could find it on my Slack channel because we were talking about it at work.
Well, you find it, drop it in, and I'll put it in for the show notes. Cool. All right, hit me with your case.
Oh, we're going 1 for 1.
Yeah. 1 for 1 times 2 equals 4.
Okay. Well, my case was this week I saw someone who was a middle-aged male, and I've spoken to you about this person already. They came in very biomedically minded. They wanted sort of direct answers, someone to be able to fix them. They had seen a previous physio before, outlined what that previous physio did, which sounded like pretty much exactly what I was going to tell them to do. And it was difficult in the sense that I felt straight away that there was going to be some sort of issue with me being a young female and them being a middle-aged male who wanted the same thing that they had previously gotten from another physio but wanting it differently from me. And it was straight away I just felt like they should be seeing one of the males in the clinic, and I actually wanted to just be like, let's just pause this and let's just pop you in with someone else because I just don't think you're going to do well with me. And I approached it by trying to be quite direct and firm with what I was recommending, and I thought that was going to be my best way to possibly get some sort of buy-in, because that was kind of the terminology and the mannerisms that they were displaying to me. So I was almost trying to mirror them back to them.
Yeah.
Anyways, they ended up cancelling all their appointments, and I thought that was a possibility that could happen. And it just sort of reminds you of, like, you can't be everyone to everyone, everything to everyone. It was definitely one of those cases. But yeah, I do truly believe that there are some tricky cases like that where you can't be everything to everyone, and that's okay. So obviously I'm not going to be able to change any more to suit that person, and they might find a different physio somewhere else and get a better result just from the person that they're talking to. But yeah, it was just an interesting reflection point. There could have also been other things. That's certainly possible. But yeah, it was just an interesting scenario, like a communication scenario that I thought would be worth bringing up.
Yeah, and I think you did mention there was a big deficit. There was some clear things to work on to help out. I think. Yeah,
there was a 50% strength deficit that I was making that very obvious as to what the point of rehab was going to be. But yeah,
those cases. I mean, we've spoken about it constantly, and we will speak about it forever because those things always happen. And while we were away, I remember journaling about this because as Ray Dalio would say, it's just one of those things that comes up again, and you need some strategy or framework to be able to handle it. And what I teach with the students when I speak about this is those things will always happen. We know it's inevitable. Really, all you can do is try to take whatever you can learning-wise, understand if you can be better, talk to other people about it and coordinate and triangulate with them, and then try to really just forget about it, because it does get you down. But if you have that happen, say, a couple of times a quarter, the benefit is you do learn some pretty cool things. Oh,
definitely. I mean, this week I've considered that case more than I've considered any other cases, and I've thought of certainly something like I was like, I probably could have done more manual therapy. That might have been helpful to get a little bit more trust and try and make it feel better, which I probably didn't do during that consult because it was very information heavy. So yeah, there's certainly things that you think about and learn from and reflect on in the scenarios where you don't succeed, opposed to the ones where you do succeed because you succeed. So you just kind of move on.
Yeah. Isn't it funny how you being really confident with what you're saying to someone really instills that trust as you're the person that can help them, although the information probably we don't really know if it's accurate. Like, you can be really mechanical. Let's just say for myself, the foot rolling in, they have pain on the inside of the foot. Yep, your foot rolls in, you have pain on the inside. That is the cause. And if someone perceives that, like, oh, thank God, I know what's wrong with me, I know why it is, and they get better, and that's kind of the end of it. Whereas we, unfortunately, to our own detriment, have probably gone too far where we try to make things holistic. Like, listen, this could be it, this could be it, because we're a bit scared of maybe feelings and them being afraid of their foot. And isn't it silly that it's like that? Because you're trying to do the right thing by them, although they don't probably know it, and then you end up probably making it worse for them. And like you said, it may have been easy if you just said, I don't, let's say, we're not going to say the condition, but let's just say it was a shoulder, and you just said, yeah, I'll rub it, your shoulder's weak, that's why you've got pain, let's get it strong, rather than all this holistic stuff and trying to say it's multifaceted and all that thing.
I mean, I tried to even be a bit like that because I just thought that was going to be better for like that person to actually come back. But anyways, funny you mentioned that though. So this week I was reading an article from 1987. It's a very poorly conducted
Blake,
study.
look that up. No.
Blake, look that up. It's a very poorly conducted study. So the person that's doing the assessing is the person that's writing the research, and it's looking at I think the title is something along the lines of is there benefit in being positive or something like that. But it's comparing, this person's a doctor, the researcher is a doctor, and he had 200 patients come into the clinic, and he divided them into 4 groups. The positive group doesn't mean like being positive in terms of their tone. It was positive that he knew what their diagnosis was. So he'd be like, yep, you've got plantar fasciitis. I'm going to treat this with an anti-inflammatory, and just being really direct. What the other group was, yep, you've got plantar fasciitis. I don't need to give you any medication for it, or don't need to give you any intervention. And then the negative group was, you seem to be having some sort of heel pain. It seems to be a little bit load related, but we're not exactly sure of what's going on with you. Given the fact that I don't know what's wrong with you, I'm not going to give you any medication. And then the other last group was the same thing, like that vagueness in terms of what's going on, which is probably what we do the majority of the time. And I'm just going to give you this anti-inflammatory. The medications were placebo, so they didn't actually have anything in them. And the result was that patients were more satisfied and got better when it was more direct and they were given a clear diagnosis. So as I said, it was a really poorly put together study. It was more of like an observational piece rather than like a randomized control trial or anything like that.
It's better than not having it there.
But it is interesting because we definitely, I definitely do that, is sometimes I will be a little bit less clear and direct in those cases where I'm not entirely sure what's going on. I've probably swung a little bit more towards giving someone a more clear diagnosis, but a diagnosis that sort of encompasses lots of things. So, for example, plantar heel pain or rotator cuff related pain. Which, it sounds almost as vague, I think, but apparently patients seem to think that gives them something.
Yeah, I go a little bit, I do go specific a bit more now. Probably almost all of the time I do, but knowing in the back of my head, if I can pick the pain pattern, what aggravates it, what eases it, we can, help someone get back to that. But I wonder, another question on top of that is just how much does the diagnosis matter as well? Because you give them relatively a spot, like, yep, they've got pain on the inside, could be the tib post or the FHL. We can pretty well, or the tibial nerve, we can pretty well or we should be able to, I definitely can differentiate between them with some easier testing, somewhat accurately, rather than, say, tarsal tunnel syndrome. And if I pick the pain again, I should be able to get it. But if we talk about how much does it matter, it really does matter in the sense of potential treatment options for a nerve versus a tendon versus even if it's the tibia, if they've got like even like a medial mal bone stress. So that's another question I've been asking is, well, like, how much does it matter as well as what's going on?
Yeah, and I remember we've talked about this like a while ago, and I at the time I was sort of saying, look, I don't think a diagnosis is as important, but I like reflecting on that now, I definitely would have told them something. Like I wouldn't have said, just left it in the ether. I would have put a label on it, I suppose, because I do think that is an important part of why people come in to see us. I think the diagnosis, though, can be more like encompassing of a lot of things rather than saying you've got a retrocalcaneal bursitis, for example. That probably sits under the umbrella term of
posterior heel pain.
Yeah.
I had a case that really just made me think about the importance of screening for the rest of the body. In my case, it's the lower limb. So we always, ask, do you have any other, aches or pains, or do you have any other injuries you're managing? Are you seeing anyone else with any other regularity? And people often mention, they might be seeing a physio for their back. They've had some knee trouble in the past, or my knee's a little bit sore, or if they've had some persistent condition in the foot and the ankle, typically they might say they feel a little bit weaker or different on that other side. And I saw someone that I'd seen previously for a bone stress. Everything was going really well. They'd rehab, back to some consistent running. Everything, it was awesome. I think for 12 weeks, and then saw them again, and we were talking about something, an Achilles had flared up and had some pain elsewhere. And we went out and did some more testing to confirm it was the Achilles tendon, and kind of mentioning some more proximal pain, and it didn't really sit right. And I wasn't thinking that it could be anything kind of serious. And I was like, oh, that, almost sounds like a bone stress. And then it just kind of clicked in my mind that potentially there could be something further up that's way more serious than an Achilles tendon that's come on recently. And I actually ended up sending that person for a scan up around their hip and femur because I was concerned of a proximal bone stress injury. And it just made me think, like, yes, I'm focused on the foot and the ankle, but I need to be doing some further screening. I'm not always the person to implement the treatment, but I know enough around that. And, medico legally, we teach up to the hip and the back, and I feel confident referring and investigating that. But I'm, of course, going to get second opinions, physio, sports doctor, if needed. But yeah, it's interesting because there can be some other things happening that's going to affect what you're doing down there. If someone's got plantar heel pain and you're giving them some rehab or maybe some chin splint and they've got a sore hip or a sore back, you need to be able to at least assess or know what's happening to be able to then implement what you're going to implement.
And identify where the right person is to send them to if it feels like it is a little bit outside of your scope.
Yeah. I've seen someone once with like an acute radiculopathy that I was seeing them as a follow-up for their foot, and between that time that had happened with their back, and they'd already had seen a regular physio like a year ago, and like you need to go back to see them because we can't really do much here. I mean, that was so painful. We don't see much acute stuff really in podiatry, but they were just agonizing. I've seen people with like vertigo as well, and I've recommended neck physios when they've come in between that time, and I'm like, wow, yes, heel pain is uncomfortable, but vertigo and the back one, I'm like, you can't even move. They can't look up. I mean, I've had neck pain, and my dad's had vertigo, but I thought, wow, that's really disproportionate, Anything I say.
We have a new physio that's not new anymore. He started when I left, but Brian, he's a vestibular physio, and he talks about some of the stuff that he does with his patients, and it's just crazy. Like, it's a different space. Like that, if someone came into me with vertigo, I would feel so out of my scope. And I've done a little bit of training on
You would feel out
vertigo.
of your scope. They come to see me.
Yeah, I know. But it's just such a niche area. Really interesting, though. I think it's really cool.
I went to a talk. It was from Ben West at Regent Street. I watched him talk about vestibular stuff.
I remember that.
And I mean, I would never see anyone for their neck. If they ever came in, they'd be straight out the door to someone else. But that was so interesting. The maneuvers and things, and learning about the brain and the ear canals and the circular
and the goggles
loops.
that they put on people, and they can look at their like nystagmus.
Yeah, I thought that was really cool.
Yeah.
But my learning was just
check it all.
Check it
Head
all
to
and
toe.
ask about it, because we ask about that in the subjective history taking. But if it's reported as a concern, even asking the question, how much does it bother you compared to your foot? Like, is your knee a lot worse than your foot is? Like, do we need to look at things? And the other way it has come back to help me is I feel really confident doing proximal rehab. So if someone, and I had someone this week, they're fully recovered from a tib post and some MTSS, had a hamstring strain a while ago and hadn't done any sprinting for a long time. And they mentioned their coach from their team had said, if it doesn't get better, let's get some PRP, without recommending like any other treatment beforehand. And they got a bit of strength in there. I'm like, you just need to return to some intensity. But I gave them some hamstring stuff, but that was only because I knew that was going on, because I'd asked about anything else going on in the body.
That's funny.
Yeah. What do you think? Someone comes to see you. Oh yeah, my podiatrist gave me some hamstring stuff. What do? You go, I'm reporting that guy to ARPRA right now.
No, I would be interested as to see what the hamstring exercises were, just from like an interest point of view.
I'm only giving long lever holds.
Just to judge them, basically. Nah, just kidding. I think that's good. I think it's good to be able to move beyond just the area that you are most confident with, because I think that improves your skills. And it like, if someone came to see me for that same thing and the podiatrist had recommended to continue rehabbing with, say, myself for that, I think it would be good to give that person something to walk away with in the meantime between then and following up with me, for instance. I mean, it's not that hard, really, is it?
No, and they're the two questions I ask myself. I'm like, am I the right person to implement this based off the risk, based off what's happening? And with this, is there a big window of effectiveness? And there is. And, how confident do I feel? And I can load the hamstring. I've got a good understanding of what loads need to be applied in the progressions, and I also wrote them a return to intensity with running.
It's because you've got a proximal hamstring tendinopathy, so you're all familiar with the hamstring exercises now.
Hamstring's good. I wish the foot had big muscles like that.
It's fun, hey?
Yeah.
Lower limbs fun.
Yeah, and people typically they feel their hamstrings a lot, so they're like, oh yeah, it's working.
Yeah, it's working.
Whereas you give them the short foot and they're like, nothing. I don't feel anything, ever.
The doming.
Yeah. All right, hit us with the last case.
Last case. I had a patient, it was my first day back at work, actually, so I was like, oh, I need to remind myself how to do these big things. Had a neck of femur stress fracture, and it was 3 months post-diagnosis. So they'd been through the hospital system and been offloaded with crutches, and got cleared by the hospital to begin walking, and had follow-up imaging, which they said, the ortho said was fine. So I'm interested in that, because my understanding is that it doesn't look fine like for a while after the injury. Anyways, maybe it just showed signs of healing or callus or something like that. But I just thought it was really reassuring that that person had decided to come in to see me for trying to minimize the risk of that injury happening again, and to best prepare their body to get back into running. And they hadn't seen a physio at all during that time. They'd just been managed through the hospital, which is probably a good thing, because it is a very high-risk injury, obviously. They didn't have surgery. They just managed it with offloading. The other thing that it really alerted me to, because we did some testing as well, and there was a 60% deficit around that hip. So significantly different.
And expected,
but it's huge. So if she had followed what the ortho said, in that she should just get back into running when she's ready, that might never be really addressed.
No. I mean, we're speaking about that with Nikki on the run this morning. Like, even whether it be bone stress or even Achilles ruptures, when they're put into a boot, just go from a boot straight to walking. Like, you haven't loaded anything, not just the tendon, ligaments, muscles, joint capsules. I mean, your fascia, just your fat pad is going to be less tolerable to getting compressed.
Yeah, and it was just really reassuring to see that this person has decided to continue the rehab despite advice from the ortho. And then maybe the ortho didn't say don't do that, but they didn't recommend it clearly, because I think it's really important. It's really necessary, particularly for those big injuries. So,
yeah. It'd be great to hear where people have acquired the knowledge to make that decision. I mean, you know, and I'm assuming you do as well, have to believe that some of that comes from, you know, forums like this, the podcast, social media, people talking about these injuries in a public space. You know, you make a real, and our page is more made for health professionals, but there's plenty of people that see it who aren't. Like, oh yeah, I've had one of those injuries, or I've had a friend that's had that injury. They didn't do that. Maybe they should. It was interesting.
Yeah.
And, you know, we've mentioned this on season 2 as well. We mention it every time. The cases that we discuss aren't completely 100% the real cases. We've changed things. We're speaking more about the principles and when it matters. So we just want to say that.
In saying that, we have asked for consent as well.
Yeah, in cases where we've used a little bit more information, but we want to keep it to a limit of non-identifiable.
Navicular stress fractures. Now, I'm going to be the moderator for today's discussion because we all know that Blake can yap.
Yeah.
So,
do you have a moderator when it's just one person that you're interviewing?
Like a moderator for the volume of yapping, I think, is important.
Yeah. Well, they're important.
I like learning about this stuff.
Yeah.
We got to keep the listeners engaged.
Keep going. Yeah.
I guess with your eye expressions, that will help.
If you do like the show, or you want to support the show in any way, you can over on our Patreon. Now, it is freaking expensive. It's $1 times 3. It's $3 for the month. If you think that the show brings you any value, if any of this is enjoyable at all, or you just like to listen to people yap that are health professionals, it is $3, and the sign-up link's in the podcast. It's on Instagram. But let's get into some navicular stress fractures. What we're going to do is try and structure it through the way that you would see it. So we're going to talk about all aspects of it: anatomy, risk factors, biomechanics, diagnoses, blood supply, debate, and there's a reason I've said debate, non-weight bearing protocols, surgery versus non-surgery, imaging, and management.
How long we got?
Yeah, I reckon we'll get this down in about 40 minutes.
40 minutes?
40 minutes. But
right.
It's interesting, and I'm going to tell you something about this podcast, the Sports Medicine Project Season 2 with Blake and Kelly. There is no resource that I could find in podcast format that is directly focused on navicular stress fractures. I can't find it. And these little fiddly weird things, like that was the motivation for the Liz Frank podcast with Professor Martin Sullivan, which was 2 episodes ago. I mean, that podcast was really popular because, like, you can't find these resources. I mean, you can find them at courses, but you just don't.
I also feel like we've been on the lookout to have someone on the podcast to talk about navicular stress fractures for a while. And
then you realise that you already know him.
He's right
there. I
here.
eat dinner with him every night.
I said, I'm going to interview you. Yeah. Let's do it.
All right, let's start some facts. Let's boost the engagement. So, Town et al., 1970. So not that long ago, it's at 54 years, the first description of a navicular stress fracture. Now, I'm going to abbreviate it to NSF. Because
I don't like it.
I've got up because I'm just going to be saying it too much.
But you'll say NSS, FFS. Now remember, that's a navicular.
Yeah, I'm going to call it NSF.
Just say navicular. It takes 1 second.
Yeah, all right. I'll just call them navicular stress or something like that. So, first described, 1970.
Navicky stressy.
Now, Latin, and I'm big into Latin now, guys, because I've been to recently around Greece and learning about Greek mythology and language. And at the moment, if I look up, I'm looking at 3 little sculptures of Aristotle, Socrates and Plato.
I was wondering if they were going to come up today.
They were going to come up. They're great thinkers. You might even say that you're listening to the 2024 version of them. No, I'm not kidding. I'm nowhere like Plato. You're a little bit more like... It was Medusa, wasn't it?
Medusa?
Who's the one you say you were?
Athena?
Athena, that's right. Athena. Yeah. Athena. Latin word for navicular. A vicularis, meaning boat-like. Isn't that interesting? So I thought that was cool. Now, navicular stress account for approximately 1/3 of all stress fractures of the lower extremities, but 98% occur in athletes. Males, 20s. They're basically the three things. If someone comes in and they're a male and they're in their 20s, they're an athlete and they play any of the jumping sports which we're going to talk about, and they have diffuse midfoot pain, that's more than enough. But interesting, because female is obviously an independent risk factor, significant one for stress fractures, but males in their 20s are the most likely cohort to suffer with this.
Did you say 98% are athletes, or 98% is what you described?
No, 98% occur in athletes.
Well, what bone stress injury wouldn't occur in an athlete?
Yeah,
apart from it's like a deficiency fracture, but
yeah. There's more nuance to that conversation, but for this type, because the biomechanics and the way the navicular is in the foot, the jumping explosive sports, which obviously is correlated well with athletic sports, is just going to put it under more stress. But at 98%, that's a huge one, and that's an approximate. Because when I was looking
that's not surprising to me.
Yeah. Still, it's a high number.
Like, does a sedentary person ever walk into your office and you think that they're dealing with a navicular bone stress injury?
No, I just think 98% is a high number.
It is a high number. That is correct, but it's not surprising.
So,
carrying on.
No, you're right. It's a very high number. Not surprising to you. Surprising for me, but it doesn't take much to surprise me these days. So, yeah, mostly young males. The approximate number, reading somewhere between 1/3 of all foot and ankle, 1/3 of all stress fractures of the lower limb. Some say up to 35% of all foot and ankle stress fractures occur in the navicular. But in my clinical practice, I wouldn't see that number as high. That it's a lot more metatarsals and tibia. But I guess that doesn't include the foot and the ankle. The average duration of symptoms, and this is Sexana et al., which their study is in the show notes, 8.8 months in some cases. And I've read that as low as 4 and as high as in this 8.8 to a definite treatment was initiated. Isn't that such a long time?
It is a long time.
And for such a serious injury.
Yeah, it's
I
crazy.
just couldn't believe that. So, just speaking, what about in your clinical practice? How many naviculars? You see them often?
No, you know what? There's this one person that I think about regularly, and it fits that entire description that you just mentioned of who is most at risk of developing a navicular stress fracture. And I remember palpating right on the navicular, and it was sore there. They were getting night pain, work, like all the typical signs of a bone stress injury. And I tried to get them in to see the sports doctor, but they didn't want to wait that long to get there. So they just decided to get an MRI. They ended up going to their GP to get an MRI.
Yeah.
And it came up as clear. And they just self-managed. They were like, oh, it's all clear. It's not that. So I'm just going to manage it. And I just never saw them again. And it just annoys me to this day because I'm like, I'm certain that there was still a navicular stress fracture in there.
Yeah. Well, we're going to talk about imaging, and in those cases, up to 71% can be missed with MRI. That's only based off
its anatomy.
Yeah. I mean, people say it's shaped like a bone. I don't really.
I mean, it's an irregular bone, isn't it? Is that the description of that type of bone?
Yeah.
So it's a boat-shaped irregular bone.
But I'm not going to talk about it like a boat. Let's move on.
Let's talk about
stuff.
it like a navicular.
Yeah, that's a good plan for this podcast on the navicular stress fractures. All right, so if I want to describe the anatomy, is if you are able to think, kind of visualize it in your mind, if you see it on the internet, and if you go to my LinkedIn or Instagram, there's some pictures of it. But the way to think of it and the way we're going to talk about it is from different angles. So we can have looking from the rear foot, or the calcaneus through the foot, looking from the front and looking from the side. So if you're looking from the back of the foot, where the calcaneus sits and going through, you've got the proximal surface, and that's all covered with articular cartilage, and it is what they call, which I learned, I would always just call it concave, but it's called bioconcave, which just means it goes in like you're walking into a cave, and the other side, which is the distal part, is convex or bioconvex, and the top, the dorsal, is bioconvex as well. An easy way to think of it, if you have, let's say, a ball of Play-Doh, and you push your fist into the Play-Doh, when your fist touches that Play-Doh, it's going to go around there, and if you remove it, what was in contact with the Play-Doh, that would be concave, and on the other side, it would be convex. So that's the easiest way to think of it, and then you kind of turn it on its head and turn it on the side. So it's really important to think of the anatomy, because when we start to talk about the biomechanics, why they can be a real pain to treat and take a really long time, that has a huge effect. Does that make sense? Play-Doh analogy?
I've always thought of concave as being like a cave, so it's inside. So that's what helps me remember it. But the Play-Doh works well too.
Play-Doh works too. Right, distal surface articulates with the three cuneiforms, medial, intermedial, and lateral, and then you've got, in some cases, and when I was reading, there's some differentiating anatomy, which is, the case with everything in the body, but there's some differentiating anatomy if it articulates with the cuboid. But we're just going to speak proximal, distal, and the dorsal. The plantar surface is concave as well. And it sits, when you look at it on a foot, it just sits in the middle, so it's kind of wedged between everything.
Yeah, it's just kind of a space filler.
Yeah.
Isn't it? Amongst all the, I suppose they all are, but they all just fit together, don't they?
And when they come into the clinic, it's, you can palpate the navicular pretty easily, and you don't have a lot of anatomical structures around it. I mean, you've got the tib post on the medial side, and I was thinking, before recording this, if that would change, if someone has an accessory navicular, would that change some of the force distribution? Because there was a study from Tusada et al. Saying that 21% of people have an accessory navicular, and I don't know how much that would change. I'm assuming it would be less force, because that has implications for stress on the bone as well. And then plantally, you've got the plantar calcaneal spring ligament attaching there, which obviously, if foot type comes into it, which we will talk about, that's going to have some implication. If someone has quicker pronation or a higher end range, you can have a bit more strain on that plantar ligament. So that's the anatomy.
And then in terms of, are you going to talk about biomechanics?
Oh yeah, we're going to.
Later or now? Because I've got a question.
Yeah, hit me with it.
So my understanding of why the navicular is a little bit more unique, given its shape and its positioning, is that the loads that are applied to the navicular is more of like a compressive type of load. So it's load that's going from, that's like squishing it together almost.
Yeah.
And that's what is creating that excess stress that can lead to stress fractures or bone stress injuries. Is that accurate? Yeah,
the whole foot, from a recent paper which is called Chasing Footprints in Time, but that paper kind of accumulated all the theories we have on how the foot works, and it was really quite eye-opening in the podiatry world and the biomechanics world. So a lot of the theories previously we thought about the foot, how it being really mobile and a rigid lever, played into a lot of how we thought stress was applied to the foot, because we know there's some areas that are under higher and less stress. So I can't really speak exactly what he's saying within each foot, because there's big variation and there's some compelling theories out through there. But what I can say, pretty convincingly, I think we're going to have some degree, of course, of subtalar joint pronation. So the subtalar joint comes in and the mid-tarsal joint is going to supinate, and we're going to get some stiffening of the foot. Now, it's probably less stiffening than what we thought, but we're going to get some stiffening, some pliability in the foot. And it has to be, because it's going to be able to hold our body weight if we're running and walking and jumping forward. So when the foot, let's just say, is stiffer, as we spoke about with the anatomy, you're going to have a lot of force around the navicular applied. And because you've got so many articulating surfaces, plus the spring ligament underneath and the tib post, it really does get pulled apart and over. So we think of that shape that we spoke about before. On top, if you're getting it pulled round and down as the weight's coming through, you're going to get, in some cases when it's trying to heal, bone being pulled apart, but you're going to get quite a significant amount of force through that part, on that tensile force in through the top of the bone. So you imagine if they do break down, bone cells are trying to come together, and every time you do something, you're pulling them apart. So that's why they have to be, which we'll talk about, non-weight bearing for 6 weeks, because any load applied to the foot at mid-stand is going to pull that apart. Yeah.
I think I was meaning more so compressive force, as in like the talus is sort of getting, and maybe it's in that situation where the foot is stiffening, the talus is actually pushing towards the navicular. Yeah,
because the talus is, the navicular is between the talus and the cuneiform.
Yeah.
And the navicular transmits force from the first and second metatarsal cuneiform, like during foot strikes. So you see a force transmission in through there. And because the tenonavicular joint gives the foot a lot of mobility, you're going to have force through the talus gets transmitted to the navicular, and you've got to have a pretty stable forefoot, which is pivoted on the ground. So you're going to have some twisting and kind of torsional forces into the navicular. And it's in the middle. Like it's the one that really is under force all the time. When we look at some of the other biomechanical, anatomical risk factors,
it's like a load distributor, but everything's got to go through it.
Having your forefoot adducted are going to put a bit more force into that navicular. And of course, the tib post, I mean, that's a pretty powerful plantar flexor, more powerful inverter and plantar flexor. That's going to apply some force to there as well.
Yeah, okay.
Yeah.
And so then does that tie into risk factors as well? Like, for example, like is an accessory navicular a risk factor, or do biomechanics predispose someone to developing a navicular bone stress injury?
Yeah, the risk factors are tricky because what we can say, certainly if you've had a previous stress fracture somewhere in the body, in the lower limb, you're going to be at a higher risk of having one again. We know that pretty convincingly. There was one military study where they looked at people who had a previous navicular one. Their risk is going to be higher again than if you've had a previous one.
In a navicular again.
Yeah, in the navicular again. So as I said, young males, definitely, if you're playing sports that are explosive, basketball is really high, middle distance running where, you're running...
Up on your forefoot.
Yeah, you're running on your forefoot and you're running pretty quick and the longer. And I reckon that the middle distance people can run at a higher intensity, or potentially their week is, as a percentage, a little bit higher. So they might do, say, a marathon runner, 20% of their week is at a higher intensity. For a middle distance runner, it might be 30 or 40 because they're doing overall less volume, but a bit more intensity to stay sharper.
But then their volume is still high.
Yeah, well, yeah.
That's a good point.
Yeah, so they're the ones, I mean, they come in and they're doing that and they've got diffuse, midfoot pain, you've got to be concerned with that. But they're the ones that have been mostly identified in the research, and then also bone morphology. We know genetics plays a big role in any stress fracture, purely just some people have smaller bones. But for the navicular, if we're thinking about the shape and size, if it's thicker or it's rounder, it's going to be able to tolerate and transmit more force. So the morphology of the bone, which there is big variation in the actual shape of the bone, and there's big variation in the blood supply, which we're going to talk about. So that has to be a risk factor. But obviously you can't speak to people about that. It's just going to be the case.
And so do you have any insight into why females are less likely to develop a navicular bone stress injury?
I don't know. Maybe the sport. I think I would assume that more males play things like basketball, because I keep saying basketball, but that's the one where it's been reported on the most. I don't know about the running of middle distance, more common in males, but yeah, I don't know the reason for that. Potentially other bones break down first. I don't know.
Yeah, I don't know either.
Yeah.
I wonder if it has, I was just thinking if it had anything to do with, similar to like a patella tendinopathy, where you almost have to be strong enough to put a particular type of load onto that area. I wonder if there could be anything like that in the navicular, but I guess it would be all relative. So
yeah,
it wouldn't. I suppose females are more likely to get majority of bone stress injuries, but it's just interesting that the navicular is so uniquely biased towards males.
Yeah. Yeah. Some other biomechanical anatomical risk factors, a metatarsus adductus, which where the forefoot comes in relation to the midfoot. But, I couldn't find any force data to theorize how that would increase the force through there. But I was thinking, potentially with a medial transfer of the force through the forefoot, the midfoot might be under more stress rather than going through the whole of the forefoot because it's going to be adducted. Maybe so the navicular is kind of the last stop and cops some of that force. But I couldn't find any force data to say how that changed. Reduced ankle dorsiflexion, limited subtalar joint range, which makes sense if the subtalar joint's a little bit stiffer. Generally, the force is going to be transmitted to the next proximal joint, which is going to be around the T&J and the navicular. Short first met and long second metatarsal. I think the longer second met, we know that's a risk factor for second met stresses, but potentially, if the second toe is bending up more force through the second met to the cuneiform to the navicular, it's kind of a bit more in line. And a lot of these things you can't change.
I was going to say, it's
anyway.
Like the only clinical relevance I can see for this is if someone comes into the clinic and they're like, I really just want to try to do everything I can to avoid a navicular bone stress injury. And you're like, okay, well, let's work on your ankle dorsiflexion then.
Yeah, how much are you going to get there? And how much is that going to move
Or
the
I
needle?
guess if it's, or if someone's already had it, is that something that you focus on during your rehab to try and minimise the risk of it happening again if it is more likely for it to happen in the navicular again. So I guess they're just the hanging fruits that you could pick away at. But yeah, you're right. How much of an influence would it have? Don't know.
Yeah, there was one study from Becker et al. Which compared the foot kinematics between runners and non-runners and looked at people that had a navicular, what did they have going on with the way that they move, decreased plantar flexion range of motion, greater hind foot eversion, which is just the rear foot rolling in, and reduced forefoot abduction excursion, which is kind of the end range of the forefoot coming in. And they concluded that ultimately an inflexible foot may predispose to these injuries due to increased stress across the navicular. So what I take from all this kind of kinematic research is it seems to be potentially an inherent sweet spot of the pliability of the foot, which kind of is stiffness, where, a foot that's too stiff seems to have higher forces, and a foot that's really flexible seems to have higher forces as well, because previously thought with biomechanics, if you pronate, if your subtalar joint pronates quite a lot, your TNJ or your midfoot really struggles to supinate and get into a nice foot position, and you kind of see that with people that have adult acquired flat foot, where you give them an orthotic and their foot really does function a lot better, and they're a lot more fluent through gait. And if they're really pronating through the subtalar joint, you're going to see a lot of force through that navicular. So it's kind of this flexible, non-flexible, and somewhere in the middle potentially. But again, can't really change it. You can influence it a little bit, maybe with some offloading stuff, but that doesn't move the needle that much.
And you probably wouldn't influence that until after. Like, it wouldn't be something you could do preventatively.
No, but in saying that, so one military study gave people custom foot orthoses and found that it did reduce the incidence of stress fractures.
Before they'd ever had one before?
Yeah, and that was an RCT. So that reduced the incidence of, although it was lower limb stress fractures, but reduced that incidence. But again, does that mean that everyone with a bit stiffer or less stiff, or, they're going to be doing more training, could use a foot orthoses? I'm not against it. Like, if you had a group of people that are going to train hard for 6 weeks, just trying to think of the potential harm. I mean,
I guess it's moving load around into an area that the body might not be able to deal with. And so if you gradually ease someone into the orthotic, which I'm assuming you would, then I couldn't see the harm either. Apart from them thinking that they need to wear an orthotic for reasons.
Because it's not going to... I mean, we've spoken about you can't take all the load away, but from what we're learning about bones, if muscle contraction is the big factor and you give someone a foot orthoses, they're not going to have to contract their muscles as hard, because the foot orthoses are going to be doing a little bit of work for them. So let's say my arch is flattening and all the muscles that control that motion are going to have to work really hard. Typical, normal. If I put a foot orthoses under there, I mean, you're going to theorise and tell me if you agree or disagree that they're not going to have to contract as hard because the orthotic is providing some stiffness to the joints. So, of course, it's going to reduce stress on the bone. But then where does that go? Does it go more proximally?
Well, it has to.
Why would it?
Because it can't just disappear, can it? Like, if you're running 5-minute Ks without an orthotic and then you're running 5-minute Ks with an orthotic, that load is still going through your foot. It's just not being applied.
I'm assuming some that's going through the foot orthosis. Because, I mean, I know you can't take energy away. This is getting into physics, but you can transfer energy.
But so it's getting transferred somewhere else in the body.
Can it not be transferred to the foot orthosis?
I don't think so.
That would be an interesting study.
Because think about super shoes. The forces don't go away.
No, that's...
What's the difference? It just gets moved.
Yeah. I don't know if it's the same analogy. So you're saying that you're going to have more hip flexion when you're wearing a foot orthosis? No,
but if you're trying to minimise the load, like, medially, then it might just be shifting more laterally.
Yeah. Yeah, potentially. That's a really good one to think about. I want to think about that a little bit more. Yeah. But risk factors, not that much. Of course, all the other bone risk factors, hormonal stuff, RED-S, that kind of thing, previous big increases in training load, all that type of stuff is all relevant, but specific to naviculars is a little bit different.
And then biomechanically, we spoke about that a little bit just before, but is there anything else in the way of biomechanics that is uniquely relevant to the navicular?
Not really, other than what we spoke about. Like that's kind of the crux of it. I don't really know if understanding it that much more is going to yield that much more benefit, because we know everyone's going to be individual. And the biomechanics, yes, plays a bit of a role in it. I guess it gives you more justification, because for orthotics and shoes that are going to probably do the same thing. I mean, shoes with a higher pitch and shoes that may be a little bit wider and have a wider geometry with the foot orthosis in there. And as we're going to speak about, people can have pain for a long time. Most people get back to activity. I think it's about 98%. But could that be a little bit better with a foot orthosis? That would be a really cool study to do, to have people kind of foot orthosis first on and just see if they get back quicker and if they report feeling a bit more comfortable. Because the ones that I've seen, it makes so much sense, because foot orthoses generate their force. They generate a supinatory force under the area of the navicular, basically.
Blake, look that up.
No, you can say it when you're looking at me. But that would take a while to look up. So, yeah.
So then how are you diagnosing these injuries? So is it often the case where patients are coming in, they've got a pain over that medial aspect of their midfoot, and they're male, they play sport, they've had an increase in their training load? Like what sort of questions are you asking, and then what assessments are you doing?
Yeah. So with bone stress, I think my threshold is a little bit lower, certainly for imaging, just because of the consequences of these ones, and because the research just suggests that the time to diagnosis is so long, like we spoke about, it'd be 8.8 months, or the initiation of treatment. So there aren't many things in the midfoot. I think in my clinical head, if someone comes in with diffuse midfoot pain, the things that I want to rule out, if that's all they told me, said, I have midfoot pain. Let's say they put that on their new patient form. I want to rule out and make sure it's not a Liz Frank. And I want to make sure that it's not a navicular bone stress, because they're pretty serious ones. And we've got some pretty clearish tests to be able to think, all right, we need to investigate this further. But the real ones are going to be, potentially a male in their 20s. Almost always there's an increase in training load quite quickly, and that can be not just running and jumping, but they might have kept their running load the same. They might just be walking more. They might have got a new dog and they're walking the dog more, or they're doing something more on their feet, or they just started, in addition to their running, started playing basketball or volleyball. So that's what I'm looking for. And if they have pain around or at the navicular, all the research suggests that it's really diffuse. So they'll just kind of say it's in this area on the midfoot. And there's not a lot there. I mean, unlikely to have like a tiband tenosynovitis. It's not going to be midfoot away. They might have a joint injury, but you're going to be pretty well able to palpate that navicular. The end spot's reported between the dorsal middle of that part, and then of course hopping. They did report in the literature that you can abduct the forefoot on the midfoot, but I've never done that to see it to be positive, and I guess that just puts a bit more stress on the navicular. But vague midfoot pain in someone that's increased their training load and pain to hop and they're pointing to the navicular, you've got to be concerned.
I always find it interesting when you say that there's not much else there, because I find the foot to be quite a convoluted area where there is a lot of things overlapping one another.
Yeah, tricky old thing, the foot. Well, you're looking at my foot now. When you think of the anatomy, and I teach the students to think kind of from superficial to deep, what it could be, and then when you hear trampling, no, when you hear running, hooves. What's the one where you hear something, think horses, not zebras?
Oh yeah.
I think it's, I don't know if I say trampling, because that's like killing people. When you hear...
Stampede.
Maybe when you hear a stampede, that's definitely wrong. I think horses, not zebras. So then you just think of the most common things and about that person. And that's why the incident research is cool, because you sometimes think...
I don't like that though.
What do you mean?
I don't like it when people talk about like statistical likelihood of it being one thing versus another, because...
But it gives you another data point.
It does, but there is still the chance that it could be a zebra. And I just don't think it's helpful, because there is always a chance that it's going to be the 1% weird thing.
But we have the data to say, if you were to compare them, it is, and if you look at it in isolation, yes, I'm saying that you shouldn't just base the statistical stuff, but it is another data point that does move the needle a little bit. Someone comes in, a 75-year-old female with midfoot pain.
You're thinking more OA.
Yeah, because their age,
Yeah.
and a little bit about what we know, the incidence and things. So I think there's a little bit of value in it, but I'm happy to be wrong on that.
I guess you're right. I guess that's something that you just do inherently without even thinking about it. Sometimes I get frustrated with that statement because I don't feel like it's always that helpful, because there is always the chance that it could be the other weird thing.
Yeah, you're right. And as you said, in isolation, it's not going to give you that much value. And you obviously pair it with your clinical stuff.
Yeah.
But for me, in that area, I mean, there's, like, you got the Navicular joint, got the tib post, but that's on the inside. Over the top, you've got, your extensor tendons, the tibant, the joint capsule, and the bone. And as you said, if someone's got pain there, with some of these other things that were spoken about, it's like, well, that's enough.
Why do you say that it's not a tibant tendon?
Or how often would you see, and this is again using incidence, how often is it reported, and do you see a tibant tendinopathy or a tibant tenosynovitis? I feel like that's not any more or less common than a navicular bone stress injury. Do you think? I think the navicular is more common.
Maybe that's just what you're seeing.
Yeah. I mean, how much literature have you read on tibant tendinopathy?
Not much off the cuff right now, but I do think it's a possibility that could
Blake, look that up.
Blake, look that up. I don't think that that's a unusual presentation or diagnosis, or more like a tenosynovitis, I think.
Yeah, I've seen like 2 in the last couple of years. Yeah, I mean, maybe you're just a tibant girl.
Maybe.
Yeah. Okay, well...
But like someone who's been doing a lot of uphill walking or doing a lot of stair stuff, like things that are that repeated dorsiflexion, where they get that shearing of the tibant tendon on their shoes or having their shoelaces too tight. I think that is something to develop a tenosynovitis.
So I said, if they've got this midfoot pain paired with what was spoken about. So if someone comes in and they're a male in their 20s playing basketball or running, and then they have pain on the top, are you still thinking, what are you thinking?
Well, I'd want to rule out a navicular bone stress injury.
And what do you think it's probably most likely to be?
I mean, I guess it could still,
it could be, yeah.
You've set me up that I'd say yes, but I don't think that you could...
Yeah, it's probably not a fair question.
I mean, you would always want to rule out the navicular bone stress injury just based on the risk of missing it. But I think it's a possibility that it could also be a tibant tendon or tenosynovitis or tendinopathy.
Yeah, let me just try and bowl you out with this one. If we think of like sports that are high tendon loads, is walking a high tendon load for the tibant?
No.
What is high tendon load for the tibant?
Doing heaps of tibant races. No, I think going like up hills or upstairs.
It's not.
Why?
It's not a high tendon load. Because you're contracting the muscle.
Yeah, it's not against body weight, I suppose. It's like open chain.
Yeah, I guess that pulls on the tendon, but we know the tendon loads are the highest when you're, like for the Achilles, max when the tendon's elongated.
Elongated, true.
So that's why, I mean, I would see more tenosynovitis. That is bowl you out.
You bowled me out.
Oh, middle stump! That just come to me too. You know, we don't often get one of those. I reckon in all the episodes we've kind of agreed to disagree, but that was a clear bowl.
Yeah, you got me there.
Far out.
I was like really trying to spark a little bit of debate today too, and I was like, "Oh, this will get you."
Going for it. But yeah, so I mean,
blood supply.
Oh yeah, the blood supply. Yeah, well, the blood supply is a funny one because I learned in university that you have, or most people have that avascular area. So you've got the dorsalis pedis come down and the posterior tibial artery come down. You have the medial branch of the DP, which is the artery around the front of the foot, and that supplies the navicular. And the way that it is, you've just got this area in the middle that doesn't get much blood flow. But the first person to report this, to give him some credit, 1958, War et al. First described an avascular zone in the central one-third of the navicular. So we think we've got the part on top. Remember, that is convex, middle, side, and side. So he was the first person to describe that avascular, and it was long hypothesized to increase susceptibility to stress fractures, less blood flow, which is really important for the bone healing. And yeah, that's what I was taught. I'm assuming that's what you were taught as well. Mm-hmm. But, yeah, the end spot, and that's where you palpate. But McCune et al. Performed a cadaver study and determined that 58.8% of naviculars had no zones of avascularity. Now, I posted this on my LinkedIn and we're posting on Instagram this week. Only 11.8% of naviculars had the classic dorsal and central zone of hypovascularity, which is no blood flow, suggesting other factors may also contribute to stress fractures. So, let's say approximate. 12% of people had that avascular. The rest, it was all over the place. Now, if you look to this paper, which is tagged in the show notes, it is such an awesome look because you see some naviculars, they're just completely covered in black, which is where they've filled the arteries up, and you can see it all over the navicular, and others where there's zones. So, anatomical variation.
That's super interesting.
Yes,
because the avascularness of the navicular is my understanding of one of the reasons for them to be so slow to heal and for them to be so complicated and high risk. But if that's not something that is as common as we thought, then why are they still so high risk and complicated and slow to heal and all of those things?
Yeah, well, maybe the ones that are slow to heal are in that proportion. The one in, what do you say, 1 in 10 maybe, that do have a pretty poor blood flow maybe.
But you wouldn't know, right? Like, how would you know?
No, you don't know.
Unless you go and do like an angiogram, is that what it's called?
I don't want to answer because I don't know the answer. Maybe I know what you mean, but they put the dye and stuff in.
Yeah.
But it probably speaks to, and I think, and it is my opinion, that's what I believe is one of the reasons why the healing times are so varied and potentially the return is so varied amongst the severity of navicular stress fractures, depending on if you've got a bone stress versus displaced versus undisplaced, which are a lot more serious. But it can be from 4.8 months to 8 months. Which is a big variation. Difference. So you pair, you think you pair someone with, let's say, some of those biomechanical variances, maybe a really flexible foot, and they have a longer second met, and they fall into the category of having a navicular that doesn't have the greatest blood flow. Those factors alone are going to do so much to impair that healing process. But, you can't screen that and say, yep, just go and see the ortho now, get their opinion.
Yeah.
And you pair that with the long time to diagnosis. But I thought that's something that I have learned completely different.
That's also interesting in that if there was a easier way for us to be able to work out whether someone's navicular has a good blood flow versus someone doesn't, that could really influence the weight bearing status if it was recently diagnosed. Because if it was a well vascularized area, then we might just say for them to put a boot on but continue weight bearing, and then once it's not sore with weight bearing, not sore in the boot, take the boot off. Whereas if it's more of the poor vascularized navicular, then you're probably going to be a lot more conservative with even the weight bearing status.
My opinion is unless it's a bone stress low grade, they just need the opinion of an orthopod or a sports doc, because as you just said, those decisions you could think, the consequences of these injuries, if they're not managed properly, is just so high.
I guess also if it's the tensile versus compressive side of the navicular would influence that a lot too.
Yeah. I don't think it's I actually don't know the data on what the incidence of the plantar surface. It's mostly the dorsal. There is one study.
Well, so that obviously is a big reason as to why you need to go non-weight bearing.
Yeah, well, there was we're talking about one study that we're talking about MRI versus CT, and I think that was 58 or 64 navicular stress fractures, and all of the little small fractures were in the dorsal aspect. So, but,
should we explain what tensile versus compression means?
Yep.
So I guess if it's on the tensile side of a bone, then every time you load that bone, the bone's getting separated. So it just makes it a lot harder for that bone to heal. Versus if it's on the more compressive side, every time you load that bone, the bone's getting pulled together. So it's a lot easier for that bone to heal with some loading. So navicular often being stressed on the more tensile side would then mean that it probably needs to be more aggressively offloaded, because each time you load through that bone, it's going to pull the bone apart, which is going to make it hard for it to heal.
One analogy I was thinking, tell me your thoughts, first time I've said it live, if you get a pencil and you put some glue, wet glue on top of the pencil, and you put some, pencil, middle of the pencil, you put some glue on top and some glue on the bottom, and you bend the pencil, the glue on top, you're going to see it become further away from each other, whereas a glue underneath, you're actually going to see it come in and thicken, and that's kind of representative of what we would see with callus on bone. Does that make a bit sense conceptualized?
I couldn't work out what type of glue I was picturing.
Oh, just normal super glue.
Okay. So like PVA glue?
Yeah, PVA glue will work. So you pull it apart, and you can, because you're pulling the glue apart, it's going to run and not come together. Whereas on the other side, which is the compressive side, just an easier way to conceptualize it, the glue will be being pushed together, so it will actually thicken but never be pulled apart.
Yeah.
Yeah.
I get
the
or
way...
blue tack? Blue tack might be a better,
you could do blue tack.
better thing to describe, I guess.
Yeah. I like
there's just so many different types of glue.
Yeah, that's true.
Tell me about imaging. So imaging is something that I think is really interesting in these bone stress injury sites. And I want to know what the best type of imaging is, but how to best go about ordering it.
Yeah, so the imaging will speak about X-ray, CT, and MRI, and some studies recommend that as a first line, people should have just a bilateral weight bearing X-ray, and then if that's negative and you're still suspicious, that have an MRI and then a CT. But in 1992, Kahn et al. Did plain radiographs on already CT confirmed stress fractures, and it was only positive in 18%, and that was 14 out of 77 people. So that's such a low number. And the reason for that is you need this osteoclastic reabsorption to occur before you're going to see those radiographical changes, which can take up to 3 weeks. So, I'm sure there is some value potentially looking for fractures and things, but if you're suspicious and you're going to be the primary management, I think looking at an X-ray, if it's in the earlier stages, probably isn't going to yield you that much. So MRI, CT, that then moves to CT is going to be pretty good for good bony detail and visualization. There's some literature to say it's good preoperatively, but again, that's not for me to look at. And there are some okay classification systems if you do use CT. But there was one study looking at called Navicular Stress Fracture Outcomes in Athletes, analysis of 62 injuries by Sextina et al. And using CT as the initial imaging modality correlated positively with a correct diagnosis of 1. In contrast, MRI, when used initially, was only 71% accurate. There's nuances with CT and MRI, so that's why, again, I think it's best to have some other people look at it. Obviously, if it's bone stress, MRI is going to be really good to detect that early bone edema and any medullary extension, which is going to be better than the CT.
Yeah, it's just surprising that an MRI doesn't even pick up, it does in 71% of cases, but that bone edema is usually the thing that you're sort of looking for, that whiteness in the MRI.
Yeah, but it might not pick up like a fracture line.
So an MRI would pick up some sort of stress reaction.
Yeah, MRI is going to be better if you're suspecting more bone stress. Going to give a better representation, whereas CT is going to give a better representation of the fracture line, which is, CT is looking at bone.
Wait, so an MRI can miss a fracture, but it will pick up a response.
Bone stress, generally speaking. Of course, we can't say clearly yes only, nothing's 100%. Even in saying that, so the other study, which was in the Navicular Stress Fracture Outcomes, when they retrospectively looked at CT studies, 11% of these 62 people, 64 navicular stress reactions, 11% missed. There were 6 small fractures missed, and they actually looked back on them retrospectively, plus some other fractures missed. So, Blake,
look this up.
So let's say an MRI might not pick up all the angles of the stress fracture, but you would expect to have bony edema surrounding
somewhere.
that. Yeah. So the concern is you send them for an MRI and you diagnose them as having a stress reaction, and it's missed a fracture.
A fracture, yeah. But it won't. It will pick up enough to know that there is something that requires further intervention for the navicular bone.
Yes. Yeah.
Whether it be a fracture or a stress reaction, it should be able to pick up bony edema of some description.
But with these images, I don't think you can ever say, or really anything is 100%. If you, which it would be a very, very rare scenario, but if someone has all the clinical symptoms and their imaging is clear, I think it's worth investigating, or just speak to your local ortho or sports doc. The majority of them are such nice people and good people, and they're happy to be able to have that discussion. Because again, it's just a serious injury. Now, one important differential, which is funny because I haven't mentioned this before when I've spoken about kind of bone stress, but Müller-Weiss syndrome, which I think Nadal had. I think that was him. This is the one that he had. I'm pretty sure. So
he just retired.
Yeah, that's a differential diagnosis for navicular stress. So spontaneous adult onset osteonecrosis of the navicular. Clinical symptoms can mimic navicular stress fractures. So on imaging, plain radiographs may look like a coma-shaped deformity, and depending on the stage, collapse of the navicular, it may occur bilaterally, and treatment is typically conservative with sometimes surgical management. So that's just something to be aware of.
So with Nadal, for example,
surely
his would just be...
I can look that up. Blake, look that up.
Blake, look that up. Would his not have stemmed from a navicular stress fracture, though?
I don't know if it's a prerequisite. It was Müller-Weiss syndrome.
Cool. Oh, it's a degenerative condition.
Well, it's osteonecrosis, which is...
But that could happen if you fractured your navicular and it didn't have intervention.
Could. I don't know.
Well, tell me about your cup of tea then, the management.
Yeah. Well, the literature's pretty clear on this, and we've got some cool studies of comparing, going weight-bearing versus non-weight-bearing. So, generally speaking, it should be complete non-weight bearing for 6 weeks. And there's a bit of debate between should that be in a boot, like a cam walker, or should that be in a cast. And that, of course, as you would know, is individual to the person. If you put someone in a cast, it is going to be good in the sense of it is protective. But, which I like this, they read in the paper, for the elite athletes, they don't do that because they get calf disease. Which I like that. It makes it sound a little bit scary, which is kind of good. And what they mean by that is just atrophy and all the changes through there. So if you put someone in a boot, they can still come out and keep their ankle range of motion while not loading the navicular. So they should be as a standard, and they're usually going to be managed, in a group, in a team, but non-weight bearing for 6 weeks. And when they have compared the non-weight bearing versus weight bearing, a study 1982 by Torg, 21 patients with navicular stress fractures. In patients with non-displaced or displaced fractures, they reported excellent success with 6 weeks of cast immobilization and non-weight bearing. When they spoke about doing it the other way, so 7 patients that were treated with weight-bearing casts or earlier activity developed complications. So I've got some literature to say that if it's too early, they're gonna struggle.
Yeah, I think that's important to mention because I know that a lot of our rehab now is very criteria based rather than time frame based, but I think in bone stress injuries you are pretty obviously waiting for that bone remodeling to happen, which is quite time frame dependent.
Yeah.
And the risk of loading too early could mean that they need to have another 6 weeks, say, in a boot or non-weight bearing, opposed to if you do that in another area where they have a flare-up, then you just offload it for a couple of days and get back into it. So I feel like it is an area where it's quite different.
Yeah. Another review by Carnell, 86 patients with navicular stress fractures, 86% healing with return to full activity at 5.6 months in those who were made non-weight bearing for a minimum of 6 weeks. Now comparing that, they reported a mere 20% success in the group prescribed weight-bearing casts or less than 6 weeks non-weight bearing. So a massive difference for people that weight bear too early. So it's a decision of the person. They're in a cast. They're obviously going to be less likely to load that compared to a boot because you can take that off and move around. And cool study, and it's kind of interesting because it just speaks to the nuance, but Torg et al., they didn't find a difference between people getting non-surgical and surgical, but there was a trend favouring immobilisation and non-weight bearing, which is non-surgical, 96% versus 82%. But surgery cases more likely to be a little bit more sinister and severe. They might be undisplaced. They might have other risk factors involved. So you might see that number just lower anyway because the cases are just more complex that are getting surgery.
Displaced, not undisplaced?
Sorry. Displaced is when the bone comes away.
More likely to be, separated.
Yes, yeah. Well, those cases are going to be a bit more complex and probably harder to manage and things. So that's why potentially that is lower. Mm-hmm. Yeah. Talking about surgery, obviously that's not
Wait. I just want to go a little bit more, actually, how do you do that? So if you decide someone should be in a cast, You just
I wouldn't
recommending...
decide that. I wouldn't put someone in a cast. That'd be doc or ortho.
Okay.
You know, these cases, just it's great to have input from other people and specialists. So there was another study by Malley et al. That had a systematic review of 200 navicular stress fractures and found the mean return to sport in surgically treated patients was 16.4 weeks compared to 21.7. But I couldn't find the classification of what they were, because obviously it matters, the grading, like the ones that are higher grade are going to take longer. So there's...
But it's shorter because the higher grades then end up having surgery, which then gets them back quicker.
Yeah. Comparing on a broad scale, like population level, there doesn't seem to be a big difference. But of course, on an individual level, there are cases where people just do need to have that opinion, and they will definitely do better with surgery. Like the non-union rates have been reported at 20% in higher and completely displaced fractures, and some people need a revision. So, that's just something to be aware of. I've seen cases where people have had surgery for this and they do have a change in their anatomy, and sometimes you could theorise that puts more force in an area that's trying to
probably
heal.
Increases the risk of things like osteoarthritis later in life.
Like pain and stiffness.
Any kind of trauma, I'd imagine.
Yeah,
which you might be able to avoid if you go conservatively.
Yeah, and looking at, which they've done some cool follow-up studies, that one we were talking about, the analysis of 62. So 7 refractures, 11.2%, occurred an average 5 years after the initial injury, predominantly in those aged less than 21, none with previous surgery. So that's interesting to think that, it's a long time. Could that have changed something in the navicular and then that put it at a higher risk? But yeah,
maybe.
One to be aware of, and we know a fair amount about it, but I think the big learnings and me diving into literature, learning more about the imaging is important, and just being a bit more suspicious if there's a clinical symptoms, getting the opinion of an ortho or a sports doc is going to be important. I can't see any cases really where it's going to be best not to have them out of a boot earlier than 6 weeks, and then your typical navicular management. And the avascularity is probably something that I've seen now and learnt to be not as common as previously thought.
Yeah, that is interesting. I think that's interesting. However, it's hard to make use of it. So you kind of have to assume that they're an avascular type, because if you're assuming that they're have a good blood flow, then you might be doing them a disservice to push them along quicker than they can.
Yeah. Season 2, first one off the books. We really are excited for what this season's going to hold.
Is season 2 going to be 109 episodes too?
Yeah, I don't know. I want to do something for 150 and 200. I want to do something in person, but it's hard because we have people all over the world. But maybe a live something now we're using a different program. We can have some people come in. That would be really cool.
That would be cool.
See you in a couple of weeks.